Today I'm going to talk about the fear avoidance cycle, which is the most common problem that we see in people living with persistent pain, the most common activity presentation. I'll try and get started with this. So first we're going to look at pain and how big a problem is it really. We'll look at some statistics, the current statistics. Then I'll talk about the most common response in persistent pain, which as I mentioned is the fear avoidance cycle, and how this contributes to ongoing disability and reduced quality of life. And next, what we as health professionals can do about it. So let's start with a little quiz just to test your knowledge. How common is persistent pain? Is that 1 in 5 people have persistent pain, 1 in 8, 1 in 23, or 1 in 100? I'll just play some thinking music while you have a little think. And the correct answer is 1 in 5 people. So actually more than 1 in 5 people, and that includes children, will suffer from persistent pain in their lifetime. And when we talk about persistent pain, we're talking about pain that lasts longer than 3 months or longer than the expected time for healing. Just another little quiz for you, true or false? Persistent pain has an estimated annual economic impact of 139 million Australian dollars. True or false? That would be false. So try $139 billion. So persistent pain remains one of Australia's largest health problems, and arguably most undertreated as well. So Pain Australia did commission Deloitte Access Economics to establish Australia-wide socio-economic impact of pain and look at the cost effectiveness of 3 interventions. Persistent pain was found to have an estimated annual economic impact of $139 billion. That was in 2018, and that's expected to rise to about $215 billion by 2050. And so those costs are associated with healthcare provision, about 16.7%, but the majority of costs are associated with productivity costs, and that includes things like reduced workforce participation, reduced productivity at work, loss of future earnings due to premature mortality, and the value of informal care, so loss of income from carers, etc. And as we know, 1 in 5 Australians will suffer with persistent pain in their lifetime, and as the population ages, that cost is going to rise as well. We know persistent pain is associated with significant physical and psychological impairment. It impacts poor fitness, psychological distress, depression and anxiety. Rates of depression and anxiety are estimated to be around 45%. Low self-esteem, reduced workforce engagement are also impacted. Social isolation, decreased quality of life, and increased suicidality has also been shown, with the rates 2 to 3 times higher than the general population. So the Cost of Pain in Australia report, released in 2019, made some recommendations, and these were that a rollout of pain specialists designed and led national GP training programs, with estimated to save about $209 million in overdose-related costs for $45 million in upfront costs, and that benefit to cost ratio just in the first year was valued at 4.6 to 1. It was also recommended to double the current levels of access to multidisciplinary care with a benefit to cost ratio of 4.9 to 1. And I won't talk too much about opioids today, but we do know it was recommended to prescribe atypical opioids rather than conventional opioids, as these are overprescribed in persistent pain. There's further research needed regarding the impacts of that. So what does this mean for you as health professionals? I guess whether you're a psychologist, a physiotherapist, a pharmacist, a doctor, a nurse, an occupational therapist, you are very likely to see someone living with persistent pain. And do you know what to do about this? And do you know how to manage someone or help manage someone living with persistent pain? There are not enough pain services to manage this demand of 1 in 5 people living with pain. And unfortunately, there's a pretty poor understanding of persistent pain and how to manage it. There's a great understanding of acute pain, but persistent pain is quite lacking. So we need to really improve our understanding and knowledge as health professionals. But let's just test our knowledge a bit further. Which of the following is the best predictor of someone's pain and functioning? So you've got a multiple choice here. Is it their scans, like the X-rays, MRI scans, CT scans? Or perhaps it's the weather, whether it's rainy or stormy or sunny. Maybe it's their thinking, their beliefs, or perhaps it's their nationality. Which out of the following is the best predictor of someone's pain levels and their functioning? Make sure you choose one before I give you the answer. Okay. So if you selected A, you would not be alone, but you would be wrong. A being the scans, and you probably recognise this fellow here. This is Usain Bolt, and he is known as the fastest man in the world. He has scoliosis with a 40-degree curvature of the spine, yet he reports minimal pain, and I think we could probably all agree his physical functioning is probably better than most of us, and he's got a few gold medals to prove it. If you selected C, you would be correct. So we know that thoughts and beliefs play a huge role in someone's pain and level of functioning. We're going to learn a bit more about that soon. Talking about scans though, what do you see in this image if you look closely? Hopefully you can see something that's not supposed to be there, a nail. This is an image of a carpenter from the UK who, using a nail gun, he shot a nail through his boot. He was taken to ED in a lot of pain and distress, and he wouldn't allow the doctors or nurses to remove his boot. He had to be anaesthetised before he could have the boot removed. And when they did that, what did they find? Well, the nail had actually gone right between his toes. There wasn't a scratch on him. So this actually tells us quite a lot about pain. And if we look at the International Association of the Study of Pain, or the ISAP for short, the definition of pain has just recently been revised in 2020, but it remains pretty similar to the 1979 definition. Pain is described as an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. So if you take a close look at this definition, you can see that it contains nothing objective at all. Pain is a completely subjective experience comprising both sensory and emotional components. So you can't measure it, you can't see it on a scan or anything like that. Pain is completely what the person says it is. We know there's many factors that contribute to someone's pain experience. We know that the research shows us things like if you put a minus 20 degree rod on back of someone's hand, two groups of people, one group you show them a red light and another group you show them a blue light. The group shown a red light will report higher levels of pain and distress. So context is very important in the perception of pain, and our thoughts and beliefs are one way that this contributes to that perception. So I'm going to talk specifically today about fear and anxiety and how that can also contribute to our perception of pain. Here is what is known as the fear avoidance model of pain, which was developed by Johann Leyen back in some time ago now. I think it's 2002 or perhaps earlier. If you take a close look at this fear avoidance model, looking at firstly the right-hand side of the U shape there, you can see that in the absence of serious somatic pathology, people are usually able to experience pain, have low fear. They may experience positive affect or optimism. Priority is then given to valued life goals, and they're able to confront or approach the feared situation and thereby recover, or what we would call desensitize to the painful stimulus. We've all probably experienced that response with acute pain before, where you've experienced pain but been able to recover in a normal process. But in contrast, on the left-hand side is a persistent pain cycle. When a high threat value is perceived and corresponding negative affect, priority is given to controlling the pain. The fear and anxiety is really high, and avoidance, and this can be really overt avoidance or covert avoidance, safety behaviours are in place. They become the primary response, and they result in the maintenance of fear and anxiety. So this perpetuates a cycle of pain. Learning is established and a conditioned response forms. Unfortunately, avoidance behaviours, once they're acquired, they're really notoriously difficult to address. Pain is very motivating for people to avoid, and they usually don't really recognise it as unhelpful. And in this way, Leyland noted that it's quite similar to a phobic response. And I do apologise for this busy slide, but I thought it was quite useful for particularly psychologists interested in and did a comparison with pain-related fear and anxiety and specific phobia. And he's used a DSM-4, that was a DSM-4 criteria, so there's been some changes since then with the DSM-5, but mostly the same. If you look at the key points I've highlighted there, you'll see that similarly with a phobia and pain-related fear and anxiety, exposure to the pain-eliciting stimulus almost invariably provokes an immediate anxiety response, including avoidance and escape behaviours, increased arousal levels and hypervigilance. So in people experiencing persistent pain, we'll often notice a somatic focus. They will notice pain behaviours. They'll notice that crack of their neck or the aching, things that they would previously probably have been there anyway. But just similar to a phobic response, where often people will recognise that their fear is excessive or unreasonable, people with persistent pain, they're often really convinced that avoidance has a protective function. And this does a lot of sense because it's consistent with everything we've learned since we've been children. You know, if you put your hand on a hot plate, it burns, it's causing damage. So I really should avoid doing that. Unfortunately, with persistent pain, this message is not the same. So we need to learn something different. I do want to really highlight here before we just start treating a pain-related fear and anxiety like a phobia, we do need to make sure we rule out, sorry, not we necessarily, but that any sinister causes for the pain have been ruled out by the appropriate medical specialty. So things like fractured tumour, neurological issues, all of that have been ruled out. Any red flags? And once this has been done, then we can treat, treat the pain-related anxiety. So what's the treatment for phobia? Well, as we know, psychologists will know very well, is CBT, graded exposure, is the gold standard, and that's with pain-related fear. What I've put up here is the Lancet Low Back Pain Series Working Group overview of best practice treatments for low back pain, but this generalises to many persistent pain conditions. I've used back pain because it is the most common presentation at about 45% of the people that we see in Australia and New Zealand, as per our EPOC data, electronic data that we calculate. So some of the key points I wanted to highlight are that there are no first-line pharmacological treatments for persistent low back pain. There are no first-line interventional procedures or surgeries for persistent low back pain. These may sometimes be indicated, but the outcomes are usually better with pre and post education and some allied health input. The first-line treatments, however, that are recommended are pain education. Patients need to know that pain does not equal damage for persistent pain. That biopsychosocial factors contribute to their pain experience, and therefore we need to look at biopsychosocial treatment factors. Exercise therapy and cognitive behaviour therapy. They're all the gold standard treatments. So rather than a biomedical approach, which works really well for acute pain lasting less than 3 months, a biopsychosocial approach is really needed for management of persistent pain. So what exactly is CBT, and specifically graded exposure therapy for targeting fear avoidance? The Gold Coast did a wonderful job at highlighting the assessment for persistent pain generally, so I'm not going to spend a lot of time on this. I just wanted to highlight yellow flags, which are the psychological or psychosocial factors contributing to long-term disability and distress in pain. So particularly looking at people's attitudes and beliefs. If someone has a belief that pain is harmful and that will result in avoidance and poor compliance with exercise, we can tell pretty much that their prognosis is not going to be great, and so that's an area for intervention. If they're catastrophizing or thinking the worst, again, we need to do something about that. If they're misinterpreting bodily symptoms as something really awful or dangerous, we'd need to treat that. If they have really low confidence to manage their pain or expect the worst, all of these factors that are outlined in the psychosocial yellow flags are really important to screen for. So other things that you could look at there are the social and family environment. If you've got someone that's got family partner who's overprotective and doesn't let them do anything, that can be really tricky. A workplace where it's not very flexible, or they have a poor history, a poor work attendance, their prognosis is not generally as favourable. Looking at the behaviours, passive approaches tend to look at reliance on strategies where the patient doesn't have to do much. So using medications, extended rest, reducing or withdrawing from activity, excessive sleep, those types of activities, or using alcohol. They tend to predict longer term disability, and we want to promote the opposite of that. So engaging in active self-management approaches, which I'll talk about next. And obviously the effective responses there of depression, irritability, anxiety. Okay, so let's start with thinking patterns. The most common thinking pattern studied in pain is pain catastrophizing. We know that unhelpful thinking patterns are linked to more intense pain reports, more severe depression and anxiety, increased use of analgesics, increased attention towards pain or hypervigilance, somatic focus, and worse physical functioning. So it's a really important area for us to address. We know that even surgical outcomes are worse in people with higher pain catastrophizing. If you're interested in assessing someone's pain catastrophizing, the PCS is something we use in our pain service and across the state. The pain self-efficacy questionnaire is also really great in measuring someone's confidence to perform a range of activities despite their pain. That was also mentioned by the Gold Coast yesterday. So what do you do? What are some of the cognitive techniques that you can use in managing the fear avoidance model? You can see the fear avoidance model there, and we're looking at catastrophizing. First, you need to use your pain education. So if someone's believing that I'm going to cause damage if I do any movement, we need to address that. If they think they've got cancer, that needs to be addressed. So really, before someone can engage in CBT, they need to have any sinister causes ruled out and have some really good education about the difference between acute pain and persistent pain, the need for psychosocial treatment approaches versus biomedical approaches to get that buy-in. Then we'll look at the reappraisal of pain. So transforming pain, you can relocate the thoughts to non-pain sites using mindfulness techniques, challenging unhelpful misconceptions. And just next, I'm going to look at some ways that health professionals can help or hinder the process. This was a article released by O'Sullivan and Lynn, and these were some common danger or unhelpful messages that contribute to pain catastrophizing. So this was specifically for back pain, but any unhelpful messages that promote beliefs about structural damage or dysfunction. Unfortunately, these are used really commonly. We hear patients coming to the pain service using this language often really commonly. So, or they've been told by other health professionals that these words. And so you can imagine that this might make them feel scared about moving and might contribute to avoidance. So you have degeneration, disintegration, wasting. They may read that on their X-ray reports, for example. You've got failed back syndrome, or you have the back of a 70-year-old. You've been told some of these yourself going to see health professionals. Other things to look out for are things that promote fear beyond the acute phase. So you have to be careful and take it easy from now on. Your back is weak. You should avoid bending or lifting. That might be helpful in the acute phases, but people will hold on to that information sometimes 20 years later and not be using these muscles that they should be using. So your back wears out as you get older. I wouldn't be surprised if you end up in a wheelchair. You won't be able to work, run, play golf again, or stop if you feel any pain and let your pain guide you. These are quite unhelpful messages. So instead, what could we, or what should we be saying? I actually wanted just to add to that. I'll go back to that. I know as a psychologist, before working in pain, sometimes I would see people in pain and I wasn't quite sure what to do. So if they'd come in and talk about being in pain, I would say, oh gosh, that does sound bad. Maybe you should just go back to your doctor, which might not sound too bad, but if we're consistently referring people back to see the health professionals for the same pain, if it's the same pain that they're presenting with, they're increasing their healthcare utilisation, which is, a cost to the healthcare system, and they're not necessarily developing their own self-management skills. So if it is a change in their usual presentation, by all means, that they should talk to their doctor about it, but presenting to the emergency department for their usual pain may not be the best case. So that's something to really discuss with either their doctor or their physiotherapist if you're unsure, just to get a really good idea of what you should be recommending if you're a psychologist or another non-physical discipline working with someone in this with pain. Some of the more helpful messages that you can use instead. Pain does not mean your body is damaged. It means it's sensitized. So that alarm system is switched on. It's being overprotective. For psychologists working with anxiety, this is a really common analogy. It's like, you know, if you're going to do a speech in front of a whole heap of people, you might feel really nervous, but what are the chances of you're going to die or you're going to pass out? It's not the same as if a tiger had jumped out of the bushes at you. So we can see that our body responds in different ways, and we just need to retrain that alarm system. Some other helpful messages to promote resilience. Your back or your body is strong. You've managed things like this before. Encouraging normal activity that helps them regain their quality of life is really important too. Motion is lotion is one of the common sayings we use at the pain service. Hurt doesn't equal harm. You can be sore but safe. Movement is medicine is another one we use here. And rather than, you've got disintegration or degeneration, your scans changes are normal. They're like grey hair or wrinkles. So they're common ones our physios like to use. So they're some of the cognitive techniques. Now looking at how do we actually wind down the nervous system. You want to use, when you're using your CBT techniques, obviously you're challenging the unhelpful thoughts, but then you also need to wind down the nervous system. That's really important for managing fear, anxiety, and as well as pain, the physical tension that goes with pain. So there's a whole list of relaxation strategies that have been shown to be useful for pain management and anxiety management there. There's also, I've included a link down there for the ACI New South Wales Health website, which has links to handouts you can provide to patients that can be useful there. And finally, moving on to the behavioural techniques. This is really your general graded exposure, and this is where it's really useful to work closely with your physical discipline experts if you've got access to them, and if not, just work really closely with your patients to identify gradual steps to increase their activity levels through graded exposure. We use activity pacing. Try to get them focusing on, rather than using pain as a guide, using time as a guide and generally building up from there. So there's ways that you can, there's handouts on activity pacing and working out someone's baseline activity levels to build up from there. Using problem solving and goal setting to monitor and monitor progress. For medications, rather than taking medications just when your pain increases, using your scheduling as recommended by your doctors and your pharmacist. And if you do have access to those people that may be contributing to their pain experience, like family members, coaching them to not reinforce pain behaviours by jumping in and helping too soon and promoting that passive approach. So just some rules of thumb, and this is really standard graded exposure therapy for the psychologists in the room. You'll be rolling your eyes probably, but for those that aren't psychologists, and but also considering someone's activity tolerance when you're working a graded exposure hierarchy, but also their distress levels. So if you're a physical discipline specialist, you might be going, this person should easily be able to physically do this. I've seen them walk further than this before or lift more than this. But if their distress levels, their anxiety is quite high, their confidence is going to be low. We can actually be increasing the anxiety and thereby increasing the likelihood of avoidance if we set exposure tasks too high for them. So it's actually better to pull back and start really low first to increase their confidence and reduce your anxiety, and we'll find usually better results quicker, and then you can increase their physical activity tolerance much quicker. Also, do remember you can start with observing other people move first. You're still triggering those areas of the brain that target exposure, and then you can move to imaginal exposure before progressing to in vivo exposure. So for people who are highly sensitized with pain, who do not even want to touch that area or move it at all, they don't need to even start there. They can simply look at observing other people walking upstairs or bending over. And that can really help with graded exposure back to avoided activity or meaningful activity. And you can always alter that the exposure activity using time, distance, number of reps, etc. There's my reference list, which will be available if you want it. You can request that from us. If you have any questions, I'm happy to take those through. There's a few questions. Yep, I'll try and have a look at those. And just wanted to remind you of the other talks that we have for the rest of the week. Tomorrow is the Paediatric Persistent Pain Service, involving the family in the treatment of paediatric persistent pain, which will be great. And then we have our Director of Psychology, Vidula Gard, presenting on non-cardiac chest pain.
So just get back to unmute and ask a question.
Oh, sure. Okay. If you do have any questions, if you'd like to just unmute your microphone, I'm happy to try and answer for you.
So it sounds like a sort of a fundamental to this is introducing the idea that pain is an idea that isn't necessarily the truth, something that can be questioned, something that can be not always exactly as it is experienced.
Yeah, sorry, who am I talking to?
Sorry, this is Lee. I'm with the Maryborough mental health service, but the alcohol and other drug service.
Yeah, great. Thanks, Lee. That's a good question. And I guess, number one, we always say pain is always real. So it's whatever the person experiences it as. However, it can be moderated by external factors. So things like stress, so psychological factors like stress, anxiety, sleep can either wind up or down the pain. Even places you go or people you're around can down the pain experience as well. And that's because pain is a protector. Our nervous system produces pain when it determines we're in danger, but that can change if we feel safe. So yeah, there's a number of factors that can contribute to whether we feel in danger and whether we're threatened or whether we feel safe.
Yep. Thank you.
That's okay.
Hello, Shireen. This is Frances.
Hi. Hi, Frances.
Hi. How are you going?
I'm good.
Shireen, I just wanted to just put it out there. The thing that my clients struggle most with when they refer to a psychologist about pain is, you know, I'm being told it's all in my head.
Yeah.
And so, given that this could be a wider audience, could you talk through that, please, as to how to work through with clients who are really confronted or really on the defensive?
Yeah.
Because they feel it, but they've been told it's all in their head, or they think it's all in their head.
Yeah, and that is one of the biggest issues that we have at the pain service too. So there's no easy answer. And in fact, this talk, when I present it to at our GP workshops, I do call it "It's not all in my head." So I didn't want to overlap too much with the Gold Coast presentation yesterday. So I'm not sure whether how many people were able to tune into that, because that did cover a lot on assessment and treatment in pain. However, I think it's really important, firstly, to acknowledge people's pain experiences and the frustrations that go with living with pain. And what I find most useful is going through the biopsychosocial model of pain. So we acknowledge all of the biological, biomedical factors that contribute to someone's pain experience, and that might be medical conditions, scans. It could be, you know, that they do have scoliosis, or they do have arthritis, or they have bulging discs and things like that. And absolutely, that may contribute to a part of their pain. But we can often ask, you know, how come your pain changes over time? So you might do a particular activity. If we were to scan your back, for example, again, it's probably unlikely that you've had more degeneration or that bulging disc has changed. So how can we explain that? It's the psychosocial factors also that contribute to the changes there. And usually when we talk to people about, hey, does your pain change if you've had a poor night's sleep? Most people can relate to that. Or does your pain change with other factors like stress, or if you're having a great time with family or friends? When people start to relate to that, they can see, mostly, hopefully, they can start to see how these things can contribute to the pain experience. So we're not saying that they cause pain, that they're the sole cause of their pain, more that they can wind up or down the pain. And we tend to have more control over those factors than, say, a bulging disc, which we may be able to do much about. Does that help to answer your question, I guess, Frances?
Yes, thank you. It was a great explanation. Thank you very much for that, Shireen.
Thanks. Any other questions? We could probably send out some more information about the biopsychosocial. Or if there are any further questions, you can also email Alison Beeden at Queensland QLD health.qld.gov.au, which is on the flyer as well.
She can also send out the survey link.
And the survey link will be sent out as well for those that can't access it through the chat function. Okay.
Thanks so much, Shireen. That's great. It's Ali here. Really happy to, yeah, if you can email me, those attendees who want the recording, we can sort that out if you send me an email at alison.beeden@health.qld.gov.au. And yeah, if you want any other follow-up materials, do let us know through that email address.
Thank you, Ali. Okay, I might, no further questions then. Hopefully we can see you tomorrow with the paediatric pain service.
Thank you, Shireen.
Thanks.